Hello everybody, welcome to our grand rounds. We have a special speaker today, Stacey Shore-Welch, who works with us among other things. Let me tell you a bit about her background. Dr. Welch received a Bachelor of Science in Psychology and a minor in American Studies from Occidental College, a doctorate in clinical psychology from the University of Washington, and she did her postdoctoral work at Emory University School of Medicine. Dr. Welch is the founder and director of the Anxiety and Stress Reduction Center of Seattle, called the ASRC, which is an outpatient specialty clinic that serves over 200 children, adolescents, and adults suffering from anxiety and stress-related problems. The ASRC is part of a larger center specializing in evidence-based treatment for mental health issues called the Evidence-Based Treatment Centers of Seattle, which Dr. Welch also directs. This includes 4 specialty centers and employs over 20 clinicians serving approximately 500 patients. In addition to her clinical practice specializing in anxiety disorders, Dr. Welch is part of the clinical faculty of the University of Washington Departments of Psychiatry and Behavioral Sciences and the Department of Psychology. Her research activities include recent work on a study on treatment of anxiety disorders in primary care settings with Dr. Peter Royburn and others in the Department of Psychiatry here. The study is called the CALM study, the Coordinated Anxiety Learning and Management, and it's the largest study of its kind to date. She's received funding for her research from the NIMH and the Ford Foundation. Recent and upcoming publications include work in the Journal of Consulting and Clinical Psychology, Depression and Anxiety, and JAMA. She's also active in training and consulting with other professionals and is part of the training arm of CHAMP, the Center for Health Improvement for Addictions, Mental Illness and Mentally Vulnerable Populations, a center of emphasis at Harborview Medical Center. Today she's going to speak to us on modular treatment of anxiety disorders. Thank you so much, Dr. Welch.
Thank you. Well, thank you for having me. Is the volume okay? All right. It's always so fun to come over here, and I really feel honored to be here today. So thanks for having me. And the topic of modular treatment for anxiety disorders is one that I've spent a lot of time thinking about over the last few years and talking with my colleagues at the Anxiety Disorder Center where we do our clinical work. We are a bunch of certifiable anxiety science geeks around there. We love the science, we love the treatments, we love the clients. If you are publishing work on treatment of anxiety disorders, we're going to find your study and be reading it in our team. And, we practice in this larger community of clinicians who were so into this evidence-based treatment business that we named the whole center after that movement. And yet, there is a phenomenon that occurs regularly, has occurred to me and to my colleagues, and that is that after a while, you start to realize that a lot of the treatments you're doing do not look exactly like the manuals in which you were trained, and the manuals where all this fabulous evidence comes from. And I've had on more than one opportunity, a clinician come into my office and say with sort of a chagrined or shamefaced look, Stacey, I've been doing this thing with my client, or I've done 20 more sessions than any protocol I've seen published on OCD. Am I doing evidence-based treatment? So we've thought a lot about how to do this and what doing evidence-based treatment actually means for anxiety disorders, and are thinking a lot about something called modular treatment approaches. And so the first part of this presentation will be to introduce you to that idea and tell you a little bit about what that is. And then talk about why we think this approach makes so much sense for treating anxiety disorders. I want to give you a model of modular treatment to show you what this could actually look like, and that's taken from the child and adolescent literature, which is actually a bit in front of the curve and ahead of the adult literature in terms of actually putting these ideas into practice and studying them. So I'll show you a little bit about that, and that's from the work of Bruce Torpedo and John Weiss. and then talk a little bit about how we think modular approaches might really apply in the future, particularly to adult anxiety disorders, and talk a little bit about some exciting possibilities I think this model has for our field in mental health, which is so often very fragmented in terms of discipline and approach. So here's the problem. You may have had a situation like this or sent an email or talked to someone about an issue like this where you're looking to do evidence-based treatment but have a client with multiple anxiety disorders and maybe some other problems that really need attention as well. And it's quite difficult to find a manualized or really well-defined protocol that's been studied for that set of problems and how they all relate together. You would think, at this point in the field, we might actually have figured that out for multiple anxiety disorders and depression, but that's not so much the case either. So if you were to go and really try to do the evidence-based treatment, what's been studied, just as it's been studied, and you had a client with multiple anxiety disorders and depression, you'd probably end up with 5 manuals. And if you really dug into the literature further and tried to figure out, well, what are all the approaches that could work for this person, you might see your stack of manuals and protocols begin to increase until you had even 7 or 8. Oh, sorry about that. So I think it's interesting, personally, to just look at this in terms of just the psychotherapy tradition as it's evolved over time. Earlier models, clinicians would learn a set of principles, a set of, a theoretical framework that hung together. And then when clients came in, those principles would be applied. And so you might think about psychodynamic traditions, behavioral, humanistic. The list could really go on to any number of theoretical models, and many of us were trained in one of those models. There are real advantages to practicing this way. One of them is that that's a very flexible way to practice. You can apply your knowledge and these principles to a wide range of clinical concerns, wide range of clients, and it really puts the therapist in an expert role, which therapists kind of like and clients probably do too. There are also some disadvantages to practicing this way, and one of the big ones is that it leaves us really susceptible to clinical judgment bias. Now, this issue of clinical intuition or clinical judgment, we all really like that and like to think that that's sort of the bottom line, and I'm in the line of those people. However, if you look at the literature, dating back to the 50s, Paul Meehl was reviewing studies on how good we actually are as experts at predicting human behavior, particularly when it comes to things like treatment, who's going to respond to treatment, and how well. And reading this literature, it's actually fascinating to look at. There's a review done in 2000 that's really good and reviews 136 studies, I think is the number. And wouldn't you know it, we are not so good at predicting human behavior, especially as it comes to response to treatment. And where it gets really bad is actually when you're using clinical interviews as your primary source of data, which is essentially what we do in a therapy session. So it's a little bit humbling to think about the potential for bias and error if we're just using our clinical judgment. We can be pretty inconsistent, and there are limitations in these models in really generating cumulative knowledge and study. It's hard to move a field forward this way. So enter this evidence-based treatment movement. So contemporary interventions, there's been this huge shift, everyone's felt it, towards focusing on evidence-based treatment. So here we have these disorder-specific, step-by-step lists of interventions. Same set of procedures applied across clients. These are usually called manuals, and that's how they're studied and then published. And dissemination and training would generally be needed for each protocol. So you'd go train in, the MAPS-4 approach for panic disorder, and a CBT approach for generalized anxiety disorder, behavioral activation for depression, all of these different protocols. So there are big advantages to this too, big pros. We've made significant advances in the scientific study of psychotherapy, which is awfully hard to study. We have replicable treatments. We've, I think, improved treatment outcomes in some situations more than others, but I think there's been a real move here, and there's greater consistency and quality of care adhering to this model. But there are disadvantages too. Here are some of them that I encounter all the time. We've got multiple protocols for the same disorder. We at the clinic, we just did a series on GAD, so we reviewed all the treatment protocols with data, and then the ones that are used a lot that actually don't have a lot of data. And we realized that even within, we're a pretty tight group of clinicians. We work together very closely, meet as a team every week, and we were doing a lot of different treatment approaches for GAD, even within our group. There's a lot of overlap and redundancy across protocols. So if you start to go train in these treatments, you'll realize, gosh, they all involve behavioral activation, or they all involve cognitive restructuring, but you're going and learning the same thing and applying it in multiple protocols. And that gets even more frustrating when you have the same elements for different problems like anxiety, depression, etc. We generally don't address comorbidity so well. It's a little harder to be flexible in treatment. I think that this movement has encouraged a sort of disorder-specific thinking. It's odd to me sometimes when I have had clinicians I'm supervising or interviewing, whatever, say, well, I treat social anxiety and I treat GAD, but I don't treat panic, which is a little odd, and I think it stems from this kind of emphasis. And we may have actually gotten an increased, perhaps unintentional, focus on manuals as opposed to treatment. You know, when we went and started saying, well, what treatments work for whom? Division 12 movement of the APA being sort of the most famous of these. If you look at these lists, a lot of times you're looking at lists of manuals, specific ones that you go out and buy. And I didn't even mention another problem, which is sometimes you can't get the manuals because they're not published. And you write people, and some of them write you back, and some of them don't. And it's just a little difficult. So what do clinicians think about all this? Well, I think it's a myth that therapists don't care about evidence, and the research on this would bear that out. In general, what you find is that therapists are really supportive of the science behind evidence-based treatments, but they have real concerns about the impact of standardized manuals. So here's what the data says. If you go out and ask clinicians, this is what they worry about. When we're out there trying to disseminate evidence, this is what comes up with manuals, that the importance of the therapeutic relationship, people are worried that's not emphasized so much. All the manuals, if you've done them, I'm just finishing one myself, and I did the same thing. We have this paragraph in the beginning that says, of course, excellent clinical care is, you have to do it with all therapy, and we're not leaving that behind. But we don't actually do a lot of teaching people how to do that or making sure it's done. People get worried about individual case conceptualization not being emphasized, about, the impact of doing a real strict protocol on rapport. People worry about reduced opportunity to use clinical judgment, whether that's good or bad. People don't like it, and feel like research-based protocols might not really appreciate the complexity of the clients that they serve. So this is sort of the concern, and I think people really vote with their feet. So if you just think about the case of obsessive-compulsive disorder, now this is a disorder where there's not a lot of controversy about what treatment to do. So the treatment that almost everyone will recommend in terms of psychotherapy is a form of cognitive behavior therapy called exposure and response prevention, or ERP. So I was thinking about this, and I just went to Amazon.com and thought, all right, what's out there? So I just put in OCD, and here's what I found. Tons of literature, just tons. There were 26 resources that I would call a manual or a step-by-step guide you could buy as a clinician and use it. It's going to guide you session by session through. All of them emphasized ERP. There were over 100 books on OCD written by people who've had the disorder, family members, people writing about it. Vast majority, again, endorsing evidence-based approaches, ERP again. The consensus guidelines are very clear when it comes to OCD. ERP should be done. And OCD is sort of unique in terms of a disorder in that there's a pretty well-organized community. You can find local and national and international groups, organizations, affiliates. We have one here in Seattle, and they will all tell patients, get to ERP. Now, what actually happens out there? You know, still, less than half of doctoral level licensed clinicians who treat OCD do not use ERP. And when a form of CBT is accessible, so patients say they've had it, one study found, well, actually less than 60% actually got minimally competent treatment. And my experience, assessing lots and lots of patients with OCD is that is absolutely what's happening out there. Most patients I interview who've told me they've gotten ERP have not gotten what I'd say is even a minimal dose of that treatment. I don't think the answer to that is to write another manual or to tell clinicians that they need to do manuals. We've been doing that for a long time. So, what is the answer? Well, I don't know if this is the answer or not, but I'm very interested in this idea. And so let me tell you a little bit about it. So modular treatment is an emerging trend that's kind of popping up recently in the adult literature, has been talked about a bit more in the child and adolescent literature, towards more modular or flexible approaches to treatment. Modular approaches essentially provide clinicians with a set of overarching principles and a set of evidence-based interventions that we might call modules. You would not necessarily use all modules with each client. The order might vary from client to client. And decisions about how to do that and in what order would largely be based on the unique symptom patterns of each client and somewhat due to clinical judgment. If we think about, what would it actually mean to move from a more manualized treatment model to modular? The differences are protocol-based or more manualized treatments are more disorder specific, whereas modular treatments really target symptom patterns that are common across diagnoses. There really is a shift when you use this approach in thinking about the specific disorder and more to the broader processes that are involved or underlying symptoms. You'd use the same kinds of interventions, but how and when you use those interventions might vary quite a bit more. You might treat a client with the same disorder and have the treatment look different. And I think this kind of, really represents a shift from evidence-based treatment to evidence-based practice where we're incorporating more than just the manual. So what do clinicians think about this? Well, this is what really is very interesting to me. This is a study, the only one where people were actually randomized to learn different treatments. I'll tell you more about this study later. But this data is how clinicians who were trained in these approaches actually felt about evidence-based practice. So there in the red are the manual group. So these guys learn the manuals just as they've been studied. And their attitudes about evidence-based practice actually got a little worse. Not much, but a little bit. And it looks like that was mostly because of the concerns we talked about earlier, this issue of flexibility. Does it really apply to the incredibly complex people that I see? And then we've got this modular condition where their attitudes are actually increasing a bit about evidence-based practice. So that's pretty interesting. I have found it interesting just talking to community groups. And I've shifted the way I present. I'm lucky enough to go out and do training in anxiety disorders, which is really fun. And it's been really interesting seeing the difference in people's responses with a sort of a little shift in framework. So, interesting. Well, let's talk about anxiety disorders. So I think modular treatment lends itself very well to anxiety disorders, and here's why. The anxiety disorders really share many of the same features and symptoms. There's a lot of overlap. You can really very easily apply a CBT conceptualization across these disorders. I'm going to show you what I mean in just a sec. And there's a lot of overlap in the interventions, lots and lots. So here's the basic model. I know some of you are very familiar with this, but some of you may not be. So if you have someone with an anxiety disorder, this is kind of the basic info to know about what's going on and what's maintaining anxiety disorder, which is really being afraid of something it is actually not dangerous to you. And so if you ask the question, why does that fear persist even when there is not danger? You're going to see very predictable physiological reactivity. When that fear cue, whatever you're afraid of, comes on the scene, whether that's a worry thought or a dog that you're terrified of or a talk you're going to give, whatever it is, you're going to have sympathetic activation. Your heart's going to start pounding. You're going to have that twist in your stomach. Your palms are going to get sweaty. Anxiety's on the scene, that very uncomfortable and motivating physiological sensation. You're going to have predictable thoughts. Your brain is wired to begin to look for the danger, think about how terrible it would be if the danger occurred, think about how likely it could be, and you will think that it's more likely than it is almost always, and you're going to start thinking about how the heck to avoid it. Then you're going to have a strong urge for the behavior of anxiety, which is to avoid it. Of course, if you're afraid of something, why not just get away from it? That is the behavior. And if you can't avoid it, you're probably going to try to engage in some safety behaviors. And these processes interact with each other. So the more revved you are, the more your brain is going to start giving you those anxious thoughts. They just start whizzing across your mind. And the more of those whizzing thoughts you have, the more you're going to want to avoid, the more you will avoid if you can't, the more you avoid, the more you think the thing is dangerous, and it's very easy to just get caught in this vicious cycle of anxiety that's hard to untie sometimes. Safety behaviors, just for those of you who this term is new for, when you're anxious, you want to feel better. Nobody wants to feel anxious. It's not a comfortable feeling. So safety behaviors are these range of behaviors that people engage in when they can't avoid. And they're kind of ways to neutralize that feeling of anxiety. So they can actually help people function because they help you do something you're scared of, but it can keep you from feeling less anxious. So here's some examples of that. So say you're afraid of flying, but you manage to get yourself on that plane. You might look around the plane and start looking to see if anyone looks terrified. And if they don't, you might think, all right, it's okay. You can stay on the plane. You might feel better. The only problem is your brain has kind of learned that you're feeling to feel better because it looks safe and that you've gotten information that it's safe, as opposed to just learning that flying is relatively safe. Does that make sense? You might have a behavioral ritual. I hate to call her out, but many of us have a dear colleague who used to be here in the department, Amy Wagner, and she told me the funniest story about flying. She said that she figured out that, when the plane kind of leans over, Amy, who's this petite, tiny woman, would find herself leaning the opposite way as if to sort of balance out the plane and make sure it didn't crash. And that would be a safety behavior. That's sort of this little behavioral ritual someone might do. Safety cues are objects. This ranges from the cross you wear around your neck to your lucky underwear to everybody's favorite safety behaviors, objects, alcohol, and Xanax. That's the favored two. And then things like over-preparation. So say you're very worried about performance on a test or something, presentation at an important scientific meeting. You might prepare 5 times more than you have to and feel a little better, but learn that you were okay because you over-prepared as opposed to because you would have been okay. Does that make sense? So these are these sort of safety behaviors. So here's the deal. This is what happens. Anxiety is almost always cued. And this model we can apply across disorders. So you've got a fear cue, a stimulus. You're generally going to have a misinterpretation of threat. When we're anxious about something, we think it's more probable that bad stuff's going to happen, and we think if it happens that we will be unable to cope. So we think sort of catastrophically. You feel that subjective experience of anxiety, and then there could be this avoidant coping. Primary avoidant coping would just be avoiding the thing, not going out of your house so that you don't see a dog. Secondary would be like going to Green Lake where there are lots of dogs, but making sure you walk and the way outside and someone gets between you and dogs all the time. That's absolutely influenced, all of these things, by pre-existing beliefs, environmental factors, and all of these conspire to maintain anxiety disorder. What happens is that you stay anxious if your brain doesn't learn that something is less dangerous than you feel that it is. And these kind of conspire to keep that going. So if we look at this model and try to apply it to the anxiety disorders, here they are. I'm going to just show you an example with the bottom 4. Let's take panic disorder. So these are examples just from typical clients we treat. So this is a client who developed panic disorder. She was going to the ER a lot, worried she was having a heart attack, and started to realize that she would have panic attacks when her body would get a bit revved. So exercise and going to the gym became things she avoided because when her heart rate increased, she'd panic, and she was very afraid of that. So that would be the fear, stimulus, or cue, exercising and heart rate increasing. These are the threat misinterpretations. I'm going to have a heart attack. I'm going to pass out. She also thought that that could cause sort of, literally frayed nerves, like she'd imagine them kind of fraying in her brain and things breaking in her brain. She'd have, just this terrible experience of panic. If you've ever had a panic attack, and 1 in 10 of you have, it's just awful. It's a terrible experience. So she'd stop exercising, leave the gym, and then she'd, check her heart rate. She started wearing one of these things that she could check her heart rate to make sure it wasn't so high that she, she would die. And she had sort of a magic number in her head. Call the doctor, go to urgent care, call friends to reassure her, carry water and cell phone at all times in the gym. I don't know why water is a common safety behavior, but what can I say? All right, generalized anxiety disorder. Let's look at how this would apply to that. So here's a client who was, she would just worry a lot about her kids and her husband having something bad happening to them and have really awful images of that were very scary to her. And so she'd just check on them a lot to make sure that they were okay. Nobody had been in a car accident or gotten sick or had something bad happen. So a cue for her worry might be calling her husband and have no answer. And then the thoughts, you can sort of guess my God, something must have happened. He's in an accident. She'd get that sort of restless, moderate, uncomfortable anxiety, lots of muscle tension, increased heart rate. Now, she couldn't really avoid this cue. This is one of those things, it just wasn't that avoidable all the time. But then she'd keep calling him, multiple numbers, start texting, keep really busy and distract. GAD avoidance is really interesting and sometimes tricky to figure out. That was one of hers till her spouse got home. This is a client with PTSD. Let me show you this model who was raped near her home. And she would become afraid. She was really getting afraid to be alone almost anywhere. So one cue for her would be walking home from her bus stop after work in the daytime in a safe area of town. Wouldn't make most of us so nervous, but for her it became really terrifying after the assault. The thoughts were, I'm never safe. Someone could assault and rape me on the way home. She'd really feel terrible, find her stomach really upset, have increased heart rate just at the thought of that cue. So she'd avoid taking the bus, drive, call people for rides, or if she absolutely had to take the bus, try to have somebody to walk with her, have her cell phone there the whole time, walk really fast, carry pepper spray. Okay, all of these things we can completely understand, but we're serving to maintain her fear. OCD, last one. Let's apply this model here. So this is a client who, some of you probably treated folks who have a checking subtype of OCD. So she would think, if she might have left an appliance on in her home. And the OCD was the worst when she lived in an apartment building where she knew there were small children. She'd think, if I leave something on, I could set a fire, it would kill all these little kids. That thought was very scary. She'd think a misinterpretation of threat leaving the house would be, what if I left it on? It could burn down the house. This is easiest to treat around Thanksgiving because we all leave the stoves on for like 5 hours and nothing bad happens. That's a good little test. But anyway, get increased heart rate. Primary avoidance, avoiding new breakfast foods. Do not use the stove in the morning. Just avoid it completely. And if she couldn't avoid that, she might check the stove repeatedly. Actually, this client would check for hours and was really in trouble of losing her job. It was just really debilitating. Drive back home from work to check. call a neighbor, mentally review the whole time, this memory of checking. So you can see this model fits pretty darn well across anxiety disorders. I could bore you to tears by doing all of them, but I will not. So we've got some shared processes here to target. We've got these sort of maladaptive thoughts, understandable but not so helpful, this physiological reactivity, avoidance, and safety behaviors. The good news is that just if you look at CBT as a model, there are these interventions that could target those processes. Cognitive restructuring, relaxation, exposure, response prevention, these are all developed and, probably pretty effective because they target the things, the processes that are sort of going wrong or maladaptive in some way when it comes to anxiety. I know many of you here are over familiar with CBT, but I guessed that a few might not know what those things are. So just briefly, when I mentioned relaxation or breathing in CBT, most CBT manuals begin with teaching clients diaphragmatic breathing, belly breathing, or teaching them to progressively relax muscles, sort of manage stress in healthy ways. That's often a component of CBT. Cognitive restructuring, this is this thing that we do where we teach clients how to catch their anxious thinking and then teach them how to sort of work with those thoughts and challenge them or, address the sort of overestimation of risk or overestimation of how awful something would be if it actually happened. My favorite all-time study on anxiety is, I think it was Tom Borkovac who actually looked at how much the stuff we worry about actually happens. Any guesses? It's like less than 2%. And then of that, people say, it wasn't as bad as I thought, even these terrible things. So it's a great little study. Exposure is kind of the antidote to avoidance, as Peter Royburn would say. And this is where we actually gradually practice getting right in there with the stuff that you're scared of and gradually moving up a ladder to practice stuff that's scary. And what happens is that anxiety goes down if you can hang in there with it. It's hard to do, but it works really well. Safety behaviors, there's this CBT element called response prevention, and that's where you first figure out what they are, these safety behaviors, and then gradually try to move them out. And that's really essential with one anxiety disorder in particular, OCD. Okay. So this is the idea. Any questions, actually, about this idea of modular treatment? I'm going to show you next an example of how some people have applied this to kids and adolescents, but any quick questions at this point? Okay. All right, so this, actually, before I show this slide, part of the story of how this work developed is kind of interesting. There was a major lawsuit where the state of Hawaii had to totally overhaul their mental health services through the Department of Education. And it was just a big deal. And a team, Bruce Torpeda, whose work I'm going to reference a lot, being one of them, who came in and tried to totally change the system. And they were tasked with trying to train a lot of clinicians in this system and begin to have more evidence-based practice for these kids who had very complicated situations and very complicated mental health issues. So that, same dilemma as we've just been talking about. How are you going to train these clinicians who are already overburdened and overworked in 40 manuals, 50 manuals? There's no way, especially when there's so much overlap. It just didn't make sense. So this group started to try to distill this massive literature and figure out what were some elements in common so that we could actually train clinicians in some sort of bite-sized pieces that could then be applied more flexibly as these kids needed them. So they reviewed 322 RCTs, conducted over 41 years, this massive project. They coded 615 treatment protocols, and then did some fancy computer algorithms that I could not begin to explain articulately, but I'll give you all the references if you're interested. And basically got sort of a list of practice elements like behavioral activation, problem solving, exposure, cognitive restructuring, and then sort of figured out, all right, so of the studies that actually had a treatment that worked for a given kid, what were the elements? And what are the profiles of elements that you could say worked for a given disorder, age, ethnicity, etc. So it's a huge, huge project. And let me show you an example of what they did. So this is their review of 84 studies for child anxiety. And this is just part of the list of practice elements that they found. So if you look here at the bottom, there's that bar, the long one, exposure. What that's showing you is that of the studies that had a treatment that worked for an anxiety disorder, about 80% of the studies that worked used exposure. The next element on the list would be relaxation. So what that's showing you is that of this group of studies where they had a treatment that treated anxiety successfully, a little less than half of them included relaxation. And then you can go on up this list. So this is not telling us why these elements work or even that they're the best ones necessarily to treat an anxiety disorder, but it is telling us that of the studies that sort of won the race, that actually worked, this is what was in them. That profile would look different for autism or oppositional defiant disorder. The range of disorders might have a different sort of set of profiles. So autism would have some elements that would not appear in a treatment for anxiety, but some that would, like psychoeducation, for example. Does this make sense? Okay, so then what they did is they said, okay, let's try. Okay, before I show you this confusing slide, I did this in my clinic, and they were like, Stacy, this slide is so confusing. Take it out. But I thought it was really important, so I kept it in. But basically, here's what they wanted to do. And they actually have a software package you can buy, where as the clinician, you log on, and you type in anxious child, 9 years old, phobia. And it will spit back out at you a list of elements that has worked in the evidence for that kid with that profile. And then it'll give you these modules that you can then go out and use in your session. And their website's called PracticeWise. And a number of people in Seattle are using it. So Elizabeth McCauley's group has used it. Aaron Lyon would be the guy to talk to there. Mark Fadula at Odessa Brown got this, so they've been using it over there. And Children's is sort of toyed with it, but doesn't have that specific package. And people really like it. The only thing they don't like is after you type in a certain ethnicity several times, you find that there are like 2 studies, and it gets a little depressing. But you can kind of get some information. So with that preface, here's what they did next. They said, all right, let's see if these sort of profiles of things that worked differ for certain ages or ethnicities, so we can tell people, some added information. So for anxiety, they found that you could kind of chunk anxiety into 3 groups. This big general group, pure avoidance, which is a phobia, basically, like a study on kids who are afraid of weather, dogs, and then traumatic stress. And so what people did and treatments that worked look a little different for these 3 categories. And for the general anxiety category, treatments that worked had a couple different things for kids of certain ethnic backgrounds than generally. And for traumatic stress, there was a little difference with age. So, from all of this is what this group determined, is that modules for treating anxiety disorders in kids and adolescents are really helpful, but at the end of the day, after reviewing all this literature, what you really want to do is exposure. That if you had to do one thing, that would be the thing to do. And so all other modules are essentially organized around the purpose of getting a kiddo to do exposure. So let me show you what they did. They developed this sort of core 4 modules. And here's what they are. It's a fear hierarchy, like a bravery ladder if you treat kids, or just a list of things that make you anxious with ratings, so you can kind of tell exactly what you're afraid of and how bad each fear is. Education about anxiety, so people know everybody's on the same page. Exposure, and then sort of a relapse prevention, how to maintain those gains. So this is really different than a standard CBT protocol where everybody's going to get more than that and in a really certain order. So if you do it really by the book, you're going to do a hierarchy, fear ladder, learn about anxiety. Those are the same, but you're pretty much always going to do some form of cognitive restructuring. Some of the protocols for younger kids under 7 don't have that, but most do rewards, practice, maintenance, finish, at least. This would be like the most simple version. And they're pretty much done in that order. So if you were doing modular treatment, it would look a little different. You'd do your fear ladder. You'd teach a kid about anxiety. Then you would ask yourself, is this child ready to practice? Are they ready to go out and do exposure? And if they are, yes, then you do in vivo exposure if you could. That's where you get around the actual thing that you're afraid of. Like if you're afraid of a dog, you'd get around dogs. And if you couldn't do that for some reason, you'd do exposure through your imagination, which is another way we could do exposure. You would do as many items as you need. You'd work on maintaining gains, and you're done. So simple, clean case. Now, most of our cases are not so simple and clean, and they have interference. Or when you go to the question, is your kid ready to practice, you would say no. So then what do you do? So here's where modular treatment, I think, gets really helpful. Let's say your interference is social skills deficits. Okay, so you've got a client with social anxiety, and you figured out what they're afraid of, speaking in public, asking people to go places with them, talking to strangers. And you teach them, you figure out what they're afraid of, you teach them about anxiety, you say, are they ready to practice? And you say, no, because this person has no social skills. They're going to go out, and they are going to speak inaudibly or not make eye contact or act really weird, and people are going to reject them. And then what are you going to do? You're going to do terrible treatment that makes them worse. So you've got to teach social skills. So then you do a module for that. And in Interpeda's book, which I really like, they would have a little module on how to meet people and nonverbal skills. So you'd apply those, then you'd go back and ask yourself, okay, now am I ready to do exposure? Let's say your interference was depression. So we've probably, many of us, seen folks who, are very anxious but are so depressed that they're not going to go out and practice stuff and do exposure. So in this case, you'd ask yourself another question, kind of guided by this framework. Well, are they pretty bright? Are they really verbal? Are they older? If no, then you do a sort of simple version of cognitive restructuring. But if you answered yes to that question, you do a more complicated version. So you have these sort of modules you can pull in based on problem, what's going on, age, stuff like this. So it's still, you can see it's starting to get more complicated than this real simple roadmap, but it also might be more applicable to what we actually do in clinical practice. So at the risk of overwhelming you, I'm going to show you the whole flowchart. I know. My psychiatry colleagues told me that this would remind all the psychiatrists of I forget what it's called, like the algorithm that everyone hates. Yeah, so it's not supposed to be like that. It's actually supposed to encourage flexibility. But, basically you'd have, this is like the simple version that I showed you earlier. Here's just stuff that could interfere. And then they're giving you, creating modules from the evidence base for what to do when there's interference. So this is the idea. What about the data? Well, it's really still emerging. So there are a number of case series and case studies, mostly done by this group. They all look fantastic, but the ends aren't huge yet. This is where the real interest is, and I think we'll probably see this study within the year, because the study's done, but it hasn't been published yet. This is the MATCH trial, some of you may have heard of. So this is for kids with disruptive behavior, depression, anxiety, or a combination. And the study is on usual care in community clinics, standard manuals as they were tested, and modular treatment. And clinicians and there's random assignment to those conditions. So the paper isn't published, but from what I've seen presented informally, including at Grand Rounds here in Seattle a couple of years ago, what they're presenting is that clinicians really like the modular treatment. What was really interesting, and we'll see if it holds up in peer review, is that the modular actually looked more effective. So we'll see. It's going to be really interesting if that holds up. So what about adults? I think this core 4 idea probably really applies. If you go to an anxiety specialty clinic like mine, if we can, we're going to get right to exposure because we know that that's going to help the fastest, unless there's something that makes us think that that's not true or somebody needs something else for some reason. It's kind of how we think already. These might be other modules. You might do kind of I'm sure the standard CBT stuff would be in there. In the anxiety disorders, there's some interesting data on adding motivational interviewing to CBT. Boosts retention, looks like it might boost effects. Do we need a whole new manual where we all go and learn that one? I don't think so. I think we would need a module that we could add when we need to. Mindfulness, same kind of story. In terms of what's actually been done, it's just emerging in the adult literature. So if you start to get interested in this topic and look up the literature, you'll find some references and beginning use of this kind of model with chronic pain. There's some effort to use this idea in a geriatric mental health service in Florida. Eating disorders, people are starting to use this term with some of Fairbairn's stuff, although I don't think it would be considered truly modular by the other folks. Bipolar disorder. Mike Otto's doing a project here. The term in the adult literature is kind of confused a little bit with what's probably more accurately described as a prescriptive approach, where if, let's say, the person has a lot of anxious thinking, you would always do cognitive restructuring. More prescriptive. Modular treatment approaches would be even more flexible than that. You wouldn't necessarily do that. That makes sense. Here, the CALM study, which Peter and those of us who worked on that with him, we published our main outcomes last year. And this was a study where we worked on anxiety disorders in primary care. And that was kind of a move towards modular treatment. What we did in that study was we let clinicians flex the timing. So the patients could have had anywhere from 6 sessions to, what was it, Kristen? What was the top? Could have been a year of treatment. That treatment, we had elements that people used to treat 4 anxiety disorders. We gave clinicians kind of a guide that they could use flexibly for what to happen if the patients got really depressed, if there were motivation problems. And I think the next step to call it truly modular would be to let the modules function independently of one another. So when you really have a modular treatment, you could use one module without necessarily having taught the client the other one. And the format is supposed to be a little more uniform so that clinicians can really be flexible when they're using this stuff. We didn't do that, but it was probably a move towards this model. And the data have been shown here many times, so I won't show them here, but they look pretty good. So I just can't resist. This is my last idea. This is completely my own, and it may be, I was going to say a pipe dream, but it seems really inappropriate to use a reference like that in grand rounds. So, it just may be overly optimistic. But the example of generalized anxiety disorder. So CBT gets, the outcomes aren't bad. I do this for GAD, but they're not as good as the other anxiety disorders. And that's true even if you double the time in CBT. So it's not clear that more CBT is the answer. There's some really interesting research on just the processes that are involved in GAD and what could be done that suggest that more focus on relationships, on development, like childhood, emotion, might actually be really important. And these aren't things that we always do in a CBT manual. Most of the time you're not going to find that stuff in the manual. There was one group that added this to CBT, and they found the most whopping effect size. It was over 3. There's some interest in that field of really adding to what we traditionally do to see if we can't actually get better at treating people. And I think this is a very interesting idea for me as somebody who really likes CBT. I do lots of CBT. I'm a total believer. And I also don't think that CBT is, like the gospel, the answer. I really hope that I will continue to learn as a clinician and can learn from other approaches. I wonder and have this sort of innocent hope that this kind of approach might actually help us do that better. So if we could create modules that could teach clinicians, how do you help people explore their development in a way that is useful to help their adult anxiety, wouldn't that be fantastic? If we could actually give that in a more standard way to clinicians where they could use it as needed. This group, this is just an example of one thing that they did. I'm just, thought I'd show it for the CBT people because it's a little different than what we'd usually do. This isn't a module, but it's just an example of sort of this emphasis they had in this study I referenced on interpersonal exploration. It's nothing too complex, but this is something I wonder if we couldn't do better if we added these kind of things to more traditional approaches. So I want to make sure I save time for comments and questions. So I'm going to wrap up here. In summary, this idea, modular treatment, it really, I think, might help us use evidence-based principles and interventions in a more flexible way, where we really could do more individualized treatment planning and maybe address the concerns of all those clinicians who are asking the field to do better at giving them evidence. In terms of anxiety, we really, I think, could use this to highlight the commonalities among anxiety disorders and perhaps get more efficient and a little better at treating them. The focus on doing what's likely to work for each client within this framework of evidence-based practice is another emphasis. It's interesting and sort of fun to think about whether this might actually help us disseminate a little better or more effectively. My experience working on the CALM study and starting to, at least approach this idea more was that it was really helpful. And it never would have worked, I think, in the way that it did if we'd had a very rigid approach to treatment. Interesting to think about whether if we sort of adopted this, it would help us work together, even those of us from very different camps of psychotherapy. It's just a fun idea to ponder. So I'll wrap up there to see if there are any questions or just comments people have about this idea. Thanks so much. And I'll look at this website too. There are no questions. Yeah.
Can you talk a little bit more about where this is being used for chronic pain?
For chronic pain? Yeah, there's I'm not a specialist in chronic pain by any means, but there's one nice study, I'd be happy to send you the reference, where this was much more integrative. So they were trying to put patient into sort of symptom profiles and then give algorithms for what to do, when to include psychotherapy, for example. And so there were various modules. It's a little more prescriptive than a sort of truly flexible approach, but an interesting study. So people would come into different symptom or patient categories, and then certain modules were applied based on that. Yeah.
Well, this is really interesting, and it seems like it would also fit really well with dimensional approaches
Yeah.
to diagnosis, especially like personality disorders where there is so much overlap. Are there any plans that you know of to kind of integrate those two, or?
In personality disorders, the most research, of course, is done with BPD. And I don't know anyone who's actually doing this, although I agree with you. There's been a lot of talk about some of the newer studies to treat BPD, and they come from wildly different theoretical orientations. And what is although there's a lot of debate, and I'm not sure the field is coming together in any way, I was trained in DBT, love that therapy. When I read the other studies, I thought, gosh, there's so much overlap here, and it's a shame if we don't capitalize on that, because maybe all these different studies from different camps are actually teaching us something about processes that are really important. And if we could move, a little more together, we might move a lot faster as a field. So, not that I know of, but I think that would be great, and I've had the same thought.
Thank you so much.
Thank you. Thanks.